Seniors, what's the best blood pressure for older adults? Know the truth. Recent groundbreaking research, published just 3 weeks ago, is poised to radically alter your understanding of blood pressure management, particularly for older adults. For an extended period, medical professionals have consistently advised a target blood pressure of 120/80, framing it as the ideal and universally achievable goal, with the underlying principle being that lower numbers are inherently better, a metric to be pursued with utmost diligence. However, a pivotal study featured in the Journal of the American Medical Association presents a startling revelation. For individuals aged 65 and above, striving for this seemingly optimal 120/80 might actually be detrimental, potentially contributing to falls, strokes, and even mortality. As a cardiac surgeon with 2 decades of experience, I am compelled to share the accurate insights regarding blood pressure metrics for our senior population. Before revealing the precise target number, it is imperative to grasp the underlying reasons why this number diverges for older adults, and to fully comprehend the severe consequences of excessively low blood pressure in this demographic. A thorough understanding of the complete picture is essential before any specific numerical target can be provided. Before delving into the correct numbers or offering even a hint, it is crucial to witness the impact of seniors attempting to achieve a 120/80 reading. The fundamental truth that must be absorbed is that for older adults, lower does not always equate to better. In some critical instances, lower can be lethally dangerous. I encourage you to share your current blood pressure readings and your age in the comments below. This collective data is invaluable for understanding the real-world health landscape. Consider the poignant story of Eleanor, a 78-year-old woman whose journey profoundly shifted my perspective on blood pressure targets. Eleanor was diagnosed with high blood pressure at age 68, with her readings initially at 152/88. Her physician promptly prescribed medication, starting with a single pill. Within 2 months, her blood pressure had reduced to 138/82, a result her doctor deemed encouraging, though he reiterated the ultimate goal of reaching 120/80. To accelerate this process, the dosage was increased. 2 months later, Eleanor's blood pressure registered 128/76. While improvement was evident, it still fell short of the coveted 120/80. In response, her doctor introduced a second medication, emphasizing that this ideal number of 120/80 was crucial for her safety, minimizing her risk of heart attack and stroke. Eleanor, placing immense trust in her physician of 2 decades, diligently adhered to her medication regimen and regularly monitored her blood pressure at home. After another 2 months on the combined medications, her blood pressure was 122/78, remarkably close to the target. Her doctor expressed elation, deeming it perfect and instructing her to continue her current approach. Initially, Eleanor felt generally well, perhaps experiencing some mild fatigue, which she attributed to her age. However, she soon began to notice a disturbing pattern. Upon standing from a seated position, she experienced brief but intense bouts of dizziness, accompanied by a sensation of spinning that necessitated her holding on to furniture until it subsided. She mentioned this symptom to her doctor, who attributed it to age-related changes in her blood vessels, advising her to stand slowly. Eleanor heeded this advice, adopting a cautious and deliberate approach to standing. Despite her efforts, the dizziness persisted, occurring every time she rose from bed, the couch, or any seated position. This led to a growing sense of anxiety surrounding movement. Her daughter, observing her mother's increasingly hesitant gait, expressed concern, prompting Eleanor to explain her dizziness. Her daughter suggested a follow-up with the doctor. A nurse called back, conveying the doctor's message that as long as her blood pressure remained within the acceptable range, the dizziness was likely age-related and sufficient hydration might help. The dizziness, however, continued unabated. 3 months after her blood pressure reached 122/78, Eleanor awoke one morning with an urgent need to use the bathroom. As she sat up in bed and swung her legs over the side, she stood, and the room spun violently. Her knees buckled, and her attempt to grab the nightstand missed its mark. She fell heavily, striking her right hip on the sharp corner of the nightstand. The impact was excruciating, and she found herself unable to rise. Her husband, alerted by the crash, rushed in to find Eleanor on the floor, writhing in pain and unable to move her right leg. He immediately called emergency services. Paramedics arriving at the scene measured her blood pressure while she was lying down, recording 118/74. Upon sitting up, it dropped to 94/62, and when she stood, it plummeted to 82/54. This stark difference indicated severe orthostatic hypotension, a condition where blood pressure drastically decreases with changes in posture. The medications had lowered Eleanor's blood pressure to such an extent that her body could no longer maintain adequate pressure when she stood upright, compromising blood flow to her brain and precipitating the dizziness and subsequent fall. At the hospital, X-rays confirmed a complete fracture of her right hip, necessitating surgical intervention. Given Eleanor's age of 78, hip replacement surgery carried inherent risks, including infection, blood clots, pneumonia, and anesthesia complications. However, without the surgery, Eleanor would face a life of immobility. The procedure was scheduled for the following day and, fortunately, proceeded without intraoperative complications. The recovery, however, proved arduous. Eleanor remained hospitalized for a week before being transferred to a rehabilitation facility for 3 weeks of intensive physical therapy twice daily. This demanding and painful process was a stark contrast to her previous independence, where she managed all her daily tasks at home. Now she required assistance with every aspect of her care, from dressing to bathing to ambulation. She felt as though she had aged 2 decades overnight. After 4 weeks, Eleanor was discharged home, but she was a changed woman. A profound fear permeated her life. She was terrified of walking without her walker, of moving too quickly, and of being alone. Her daughter found it necessary to move in with her to provide ongoing support. Eleanor's world had significantly contracted. Prior to her fall, she was actively engaged in life, participating in grocery shopping, attending church services, and visiting friends. Now, fear and weakness confined her largely to her home. The most tragic aspect of Eleanor's story unfolded 6 months post-fall. Due to her prolonged periods of inactivity, fear of movement, and fluid accumulation in her lungs, Eleanor developed pneumonia. For a 79-year-old with reduced mobility, pneumonia is a perilous condition. Despite hospitalization, intravenous antibiotics, and oxygen therapy, her weakened lungs, deconditioned by months of limited movement, were unable to clear the infection. Eleanor passed away 3 days after admission. Her daughter was devastated and, understandably, filled with anger, believing that her mother's decline and death were a direct consequence of her blood pressure being lowered too aggressively. She recounted how her mother was active, independent, and happy before her blood pressure was drastically reduced. The fall, precipitated by low blood pressure, had initiated a cascade of events that ultimately led to her death. The paradox lay in her doctor's assertion that 120/80 was perfect. How could a perfect blood pressure number be fatal? This question highlights a critical misunderstanding. 120/80 is not a universal perfection. It is particularly unsuitable for seniors. For individuals over 65 and often over 70, aiming for 120/80 can be perilous, leading directly to the devastating outcomes Eleanor experienced: falls, fractures, decline, and ultimately death. I urge you to comment "dizzy" if you experience dizziness upon standing, indicating a potential warning sign that your blood pressure may be too low for your age. Eleanor's story should evoke a sense of urgency and, indeed, anger, as her death was entirely preventable. Had her physician recognized that 120/80 was too low for a 78-year-old and instead targeted a higher number, Eleanor might still be alive, enjoying her independence and active lifestyle. However, her doctor was adhering to outdated guidelines that failed to account for the unique physiology of older adults and the impact of age on blood pressure regulation. So, what constitutes the appropriate blood pressure for seniors, and what numerical targets should be pursued? To answer this, we must first understand the physiological differences that distinguish older adults from younger individuals and explain why the blood pressure rules that apply to a 40-year-old are not suitable for a 70-year-old, and why a reading of 120/80, while potentially ideal for a middle-aged person, can be dangerous for an older adult. Several key factors contribute to this disparity. Firstly, there is the issue of blood vessel stiffness. As we age, our arteries gradually lose their elasticity, becoming stiffer. This condition, known as arteriosclerosis, impedes their ability to expand and contract efficiently. When the heart pumps blood, these stiff arteries are less effective at absorbing the resulting pressure wave. Consequently, a slightly higher blood pressure is required to ensure adequate blood flow to vital organs, especially the brain. In younger individuals with flexible arteries, a pressure of 120/80 is sufficient to maintain optimal brain perfusion even when changing positions. However, in older adults with stiffened arteries, this pressure may prove inadequate. Upon standing, their inflexible vessels struggle to adjust quickly, leading to a drop in blood pressure and reduced blood flow to the brain, resulting in dizziness and an increased risk of falls. Secondly, baroreceptor sensitivity diminishes with age. Baroreceptors are specialized sensors located within blood vessels that monitor pressure changes and relay signals to the brain, prompting adjustments in heart rate and blood vessel tone to maintain stable blood pressure. In younger individuals, these baroreceptors are highly responsive, swiftly detecting a pressure drop upon standing and signaling the heart to increase its rate and the blood vessels to constrict, thereby preventing dizziness. However, in older adults, baroreceptors become less sensitive and respond more slowly. Therefore, when an older adult stands up, their baroreceptors may not react quickly enough to compensate for the pressure drop, especially if their blood pressure is already on the lower side, such as 120/80. This delayed response can lead to a significant drop in blood pressure before the body can effectively regulate it, a phenomenon known as orthostatic hypotension, which significantly increases the risk of falls. Thirdly, older adults exhibit increased medication sensitivity due to age-related declines in kidney and liver function. Medications tend to remain in the body longer and exert stronger effects. A dosage of blood pressure medication that is appropriate for a 50-year-old might be excessively potent for an 80-year-old, potentially leading to a dangerously low blood pressure. Fourthly, the risk calculus changes with age. While for younger individuals, the primary concern associated with high blood pressure is the cumulative damage over decades to organs like the heart and kidneys, and the risk of stroke from arterial blockages, the immediate threat of low blood pressure in older adults can often outweigh the long-term risks of moderately elevated pressure. A fall resulting from low blood pressure can be life-threatening for an 80-year-old, whereas a blood pressure of 140/85 might not manifest problems for many years, if ever. Consequently, the strategic approach to blood pressure management must be reevaluated. For a 50-year-old with decades of life ahead, prioritizing the prevention of long-term cardiovascular damage by aiming for 120/80 is a rational strategy. However, for an 80-year-old, the immediate priority of preventing falls may supersede the pursuit of a textbook perfect number. Now, you are undoubtedly eager to know the actual target blood pressure for individuals over 65, 75, or 80. While I will provide this information, it is crucial to first examine the latest research, which often contradicts long-held medical beliefs. The traditional guideline of 120/80 originated from studies primarily conducted on middle-aged adults, typically in their 40s, 50s, and early 60s. These studies did demonstrate that lower blood pressure reduced the risk of heart attack and stroke in that specific age group. However, very few studies specifically focused on individuals over 75 or 80, and those that did uncovered unexpected findings. The SPRINT trial, a significant study published in 2015, investigated intensive blood pressure lowering, comparing a target of less than 120 systolic with a target of less than 140 systolic. While the intensive lowering group exhibited fewer cardiovascular events, a crucial detail often overlooked is that the SPRINT trial excluded many common older adult populations, including those with diabetes, prior strokes, or frailty. Therefore, its findings may not be directly applicable to the average 80-year-old. The research I initially referenced, published in JAMA, followed over 15,000 adults aged 75 and older, representing a real-world cohort that included individuals with diabetes, prior strokes, and frailty. This study analyzed mortality rates based on average blood pressure readings. The results were surprising. Individuals over 75 with systolic blood pressure between 130 and 140 exhibited the lowest mortality rates, lower than those with pressures below 120 and also lower than those with pressures above 150. Crucially, the group with systolic blood pressure below 120 faced an increased risk of falls, syncope, fainting, acute kidney injury, and death. Conversely, the group with pressures above 150 had a higher risk of stroke and heart attack. The sweet spot, the range associated with the longest survival and optimal quality of life, was found to be between 130 and 140 systolic. This finding challenged prevailing medical dogma. However, upon deeper examination, it made physiological sense. For older adults, particularly those over 75, a slightly higher blood pressure than the traditional target ensures better perfusion of vital organs, especially the brain. It helps prevent orthostatic hypotension and reduces the risk of falls. These benefits, the researchers concluded, outweighed the theoretical increase in cardiovascular risk associated with this slightly elevated pressure. While I am moving towards providing specific numbers, it is essential to reiterate that a one-size-fits-all target is inappropriate. The ideal blood pressure varies based on individual factors such as age, pre-existing medical conditions, frailty, and medication sensitivity. The optimal blood pressure for a healthy 68-year-old will differ from that of a frail 82-year-old. Let me introduce Harold, a 72-year-old gentleman whose case exemplifies the necessity of personalized blood pressure management. Harold's blood pressure was initially recorded at 146/88. His physician aimed to lower it to 120/80 and initiated medication. After 2 months, Harold's pressure was 124/78, approaching the target. However, Harold reported feeling unwell, experiencing fatigue, dizziness, and difficulty concentrating, resulting in a significant decline in his quality of life. Upon reviewing Harold's case, I noted he was otherwise healthy, active, and free from diabetes, heart disease, or significant kidney issues. For an individual like Harold, a blood pressure of 146/88 was unlikely to be dangerous, and the medications were clearly causing substantial adverse effects. We reduced his medication, allowing his blood pressure to rise to 136/82. Harold experienced a remarkable improvement in his well-being, regaining his energy, experiencing relief from dizziness, and enjoying mental clarity. While this pressure was higher than the conventional 120/80, it was perfectly safe for a healthy 72-year-old. Contrast Harold's situation with that of Margaret, also 72 years old. Margaret, however, had diabetes, a history of heart attack, and compromised kidney function. For Margaret, a blood pressure of 146/88 was indeed risky. While reduction was necessary, lowering it to 120/80 would have been too aggressive given her comorbidities. We therefore targeted 130/80, achieving this through careful medication adjustments. Margaret tolerated this target well, experiencing no dizziness or fatigue, and her risk of future cardiovascular events was reduced. This illustrates how individuals of the same age can require different blood pressure targets due to their unique health profiles. I invite you to comment your age and any presence of diabetes, heart disease, or kidney disease using a format like 72 diabetes, heart disease, or 68 none to help understand the diverse health challenges people face. Furthermore, consider the case of Ruth, an 83-year-old woman who was frail and managing multiple chronic conditions, including diabetes, heart failure, and chronic kidney disease. Her blood pressure was a 168/92, which is considered high. Her physician advocated for aggressive reduction. However, I disagreed, believing that lowering Ruth's pressure could cause more harm than good. She was already frail, unsteady, and at high risk for falls. A significant reduction in blood pressure could have tipped her precarious balance. We therefore decided to maintain Ruth's blood pressure around 160/90, a reading significantly higher than traditional targets, but deemed the safest option for her specific circumstances. She remained stable, free from falls or hospitalizations, and maintained a good quality of life. Her physician was initially uncomfortable with the elevated reading, but Ruth felt well, remained independent, and 5 years later, at 88, was still alive, independent, and residing in her own home, her blood pressure consistently around 160/90. Had we pursued a 120/80 target, I believe she would have suffered a fall, sustained a fracture, experienced rapid decline, and potentially died much sooner. Even healthier seniors often benefit from higher blood pressure targets than younger individuals. Take William, a 70-year-old man who was healthy, active, and enjoyed playing golf twice a week with no significant medical issues. His blood pressure was 142/84. His doctor recommended lowering it to 120/80, but William felt perfectly fine at 142/84, reporting no symptoms, abundant energy, and a high quality of life. I advised William that given his excellent health, activity level, and absence of chronic diseases, 142/84 was likely an acceptable pressure. The potential benefit of lowering it further would be minimal, whereas the risk of side effects from more aggressive treatment could be significant. We therefore agreed to maintain his current pressure. William was relieved as he did not wish to take more medication. He was content with his current state, and we continued to monitor his blood pressure every few months, where it remained stable around 140/84 without complications. William continued to enjoy his active lifestyle, playing golf and traveling. It is also important to distinguish between systolic and diastolic blood pressure. Most discussions regarding blood pressure targets focus on the systolic number, which represents the pressure in the arteries when the heart contracts. Diastolic pressure, the lower number, reflects the pressure when the heart relaxes between beats. For older adults, systolic pressure is generally considered more critical. As people age, arterial stiffness often leads to a rise in systolic pressure, while diastolic pressure may remain stable or even decrease, resulting in a widened pulse pressure, a larger difference between the systolic and diastolic readings. For instance, a 70-year-old with a reading of 150/75 has a pulse pressure of 75, which is not uncommon and reflects their arterial stiffness. What is undesirable for older adults is excessively low diastolic pressure. If the diastolic pressure drops below 60, it can impair blood flow to the heart during its relaxation phase, leading to complications. Therefore, while a systolic pressure of 140 might be acceptable in an older adult, ensuring the diastolic pressure remains above 65, ideally between 70 and 85, is crucial. Eleanor's blood pressure when she fell was 122/78. While the systolic pressure was lower than ideal for her age, the diastolic of 78 was acceptable. However, the critical issue was the dramatic drop upon standing, systolic to 82 and diastolic to 54. A diastolic pressure of 54 is dangerously low, indicating inadequate blood flow to the heart during relaxation, which contributed to her dizziness and fall. Now, Let's explore what happens in the brain when blood pressure is excessively low in older adults. The brain, situated at the top of the body, relies on adequate blood flow against gravity. In young individuals with flexible blood vessels and responsive baroreceptors, this is rarely an issue. However, in older adults with stiff arteries and diminished baroreceptor sensitivity, maintaining sufficient blood flow to the brain is contingent upon adequate blood pressure. If systolic pressure falls below approximately 110 in an older adult, brain perfusion decreases. While this might not cause immediate overt damage, it can manifest as subtle symptoms such as dizziness, lightheadedness, confusion, fatigue, and difficulty concentrating. These symptoms are often dismissed as normal signs of aging, but they can actually be indicators of inadequate brain perfusion due to low blood pressure. Brain imaging studies have demonstrated reduced blood flow in specific brain regions in older adults with very low blood pressure. Over time, this chronic reduction in blood flow may contribute to cognitive decline, memory problems, and difficulties with complex thought processes. Some researchers even hypothesize that overly aggressive blood pressure, lowering in seniors, could exacerbate dementia risk, a controversial but concerning possibility. If reducing blood pressure too much in older adults impairs brain blood flow and accelerates cognitive decline, we must fundamentally reconsider our treatment targets. The kidneys are also significantly impacted. Adequate blood pressure is essential for effective blood filtration by the kidneys. If the pressure is too low, kidney function can falter, a concern particularly for older adults who may already have reduced kidney capacity. Studies have indicated that older adults undergoing aggressive blood pressure reduction sometimes develop acute kidney injury because their kidneys cannot function optimally under the lower pressure. Therefore, a delicate balance must be struck. We aim for blood pressure low enough to mitigate the risk of stroke from hypertension, yet high enough to ensure sufficient blood flow to the brain and kidneys, and crucially, high enough to prevent orthostatic hypotension and falls. This optimal balance point is demonstrably higher in older adults compared to their younger counterparts. Now, I will begin to provide specific numerical guidelines. But it is imperative to remember these are not absolute mandates. They are general recommendations that should be discussed and individualized with your physician, considering your unique health circumstances. For healthy and active adults aged 65 to 75 with no significant medical conditions, a reasonable blood pressure target is a systolic pressure between 130 and 140 and a diastolic pressure between 70 and 85. This range ensures adequate organ perfusion while still offering substantial cardiovascular protection. For individuals aged 75 to 85 who are generally healthy, a slightly higher target might be appropriate, systolic 135 to 145 and diastolic 70 to 85. This adjustment accounts for increased arterial stiffness and slower baroreceptor responses. For individuals over 85, or for those who are frail regardless of age, a target of systolic 140 to 150 and diastolic 70 to 85 is often recommended. In these cases, the paramount priority is fall prevention and maintaining a good quality of life, as the risks associated with slightly elevated blood pressure are less significant than the risks of falls. For older adults with comorbidities such as diabetes, a history of stroke, or heart disease, targets may need to be adjusted slightly lower, perhaps to a systolic range of 130 to 135, but still generally not as low as 120. Close monitoring for side effects and orthostatic hypotension remains critical. The management of blood pressure in older adults with chronic kidney disease is complex. Moderate reduction can protect the kidneys, but excessive lowering can impair renal perfusion and worsen function. Targets in these cases are highly individualized, often aiming for a systolic pressure between 130 and 140. I encourage you to comment which of these categories you fall into, e.g., 65-75 healthy, over 85 frail, or 75-85 diabetes, so I can understand the prevalence of different health situations. More important than achieving a specific number is the diligent avoidance of orthostatic hypotension. This is the critical determinant. If you experience a significant drop in blood pressure upon standing, it signals a problem. Either your blood pressure is too low for your individual needs, or your medications are too potent. To check for orthostatic hypotension at home, you will need a blood pressure monitor. Lie down for 5 minutes, record your blood pressure, then stand up immediately and check your pressure again. A drop in systolic pressure of more than 20 points or a drop in diastolic pressure of more than 10 points indicates orthostatic hypotension and is considered significant and potentially dangerous. For example, if your blood pressure while lying down is 130/80 and it drops to 105/68 upon standing, this represents a 25-point systolic drop, a clear sign of orthostatic hypotension. In such a scenario, even if your lying blood pressure appears acceptable, your medication regimen likely requires adjustment. Eleanor's severe orthostatic hypotension, with her lying pressure at 118/74 and dropping to 82/54 upon standing, a 36-point systolic drop, directly explains her dizziness and fall. Had this been assessed prior to her fall, her medications could have been adjusted, potentially averting the tragedy. Thomas, a 74-year-old man, experienced dizziness upon standing despite his blood pressure reading of 128/76, which his doctor deemed perfect. His doctor dismissed his symptoms, attributing them to other causes. However, upon testing for orthostatic hypotension, Thomas's pressure dropped from 128/76 lying down to 98/58 standing, a 30-point systolic drop indicative of significant orthostatic hypotension. Adjusting his blood pressure medication led to a lying pressure of 136/80, but his standing pressure improved to 118/72 with only an 18-point systolic drop. This adjustment resolved his dizziness, and Thomas felt significantly better. While his physician expressed concern about the 136/80 reading being higher than guideline recommendations, Thomas's improved function and freedom from falls were the paramount considerations. This case underscores the principle that for a healthy 74-year-old, 136/80 is not inherently dangerous, and prioritizing functional status and quality of life over a strict numerical target is often the most beneficial approach. To optimize your blood pressure management, I propose a comprehensive protocol for you and your doctor to follow. 1. Home blood pressure monitoring. Regularly check your blood pressure at home, both in the morning and evening, for at least 2 weeks. Document these readings to establish an accurate average, as office readings can sometimes be artificially elevated or lowered. 2. Orthostatic hypotension screening. Conduct the lying to standing blood pressure test I described. If a significant drop is observed, your medications may need adjustment, even if your overall readings appear within an acceptable range. 3. Symptom assessment. Pay close attention to any symptoms you experience. Dizziness, fatigue, or concentration difficulties may indicate your blood pressure is too low. Conversely, feeling well and symptom-free suggests your current pressure might be appropriate, even if it deviates from textbook perfection. 4. Consideration of comorbidities. Factor in your existing medical conditions, such as diabetes, heart disease, kidney disease, or a history of stroke, as these significantly influence your ideal blood pressure target. Your target should be individualized based on your complete medical profile. 5. Doctor consultation. Bring your home blood pressure log, orthostatic hypotension test results, and symptom reports to your doctor. Engage in an open discussion to determine the most suitable target for you, rather than accepting a blanket recommendation of 120/80. 6. Gradual medication adjustment. If medication adjustments are deemed necessary, implement them slowly, changing one medication at a time. Monitor your blood pressure frequently, observe for any new symptoms, and watch for orthostatic hypotension. Ensure the new regimen is effective and well tolerated before making further changes. 7. Regular reassessment. Your ideal blood pressure may evolve with age. Reassess your target blood pressure every 6 to 12 months, repeating the lying to standing test to ensure your current target remains. appropriate. I will now address some common questions. If your doctor insists on a 120/80 target, present them with the latest research, such as the JAMA study, highlighting that for older adults, a systolic pressure of 130 to 140 may be safer than 120. Most physicians, upon reviewing the evidence, will consider a higher target. If your doctor remains inflexible and you experience concerning symptoms, seeking a second opinion is advisable. If you are taking multiple blood pressure medications and your pressure remains elevated, adding another medication may not be the solution, especially if you are over 70 and asymptomatic. Discuss with your doctor whether your current pressure is acceptable given your overall health. For healthy 68-year-olds, a 120/80 target may still be appropriate, but if symptoms develop or orthostatic hypotension occurs, a higher target should be considered. Blood pressure naturally fluctuates throughout the day. Focus on your average readings over time. Never alter your medication regimen without consulting your doctor. But if you suspect your symptoms are due to low blood pressure, schedule an appointment to discuss your concerns and request a reevaluation. Patricia, a 76-year-old woman, experienced severe dizziness, weakness, confusion, and cognitive impairment after her blood pressure was lowered to 118/72. Upon examination, her orthostatic pressures revealed severe hypotension. Significantly reducing her blood pressure medications allowed her pressure to rise to 138/78, with standing pressure only dropping by 14 points. Patricia's symptoms resolved, her energy returned, and her mind cleared. While her previous doctor was concerned about the higher reading, Patricia was functioning well and living independently. For a healthy 76-year-old, 138/78 is not inherently dangerous, and prioritizing functional capacity and quality of life over a number on paper was the right choice. Consider George, an 81-year-old man with a blood pressure of 172/94. He was not on medication and felt fine. However, his daughter was concerned about the high reading. While 172/94 is elevated for an 81-year-old, the decision to treat must consider whether intervention will truly improve his life or lifespan. George had no history of cardiovascular events, diabetes, or kidney disease, and remained active and independent. Initiating blood pressure medication at 81 carries risks of side effects, including dizziness and falls. We discussed lifestyle modifications, such as reducing salt intake, increasing potassium-rich foods, moderate weight loss, and increased walking. After 3 months, his pressure was 158/88. While still not meeting traditional targets, George felt well, and we decided against medication, opting to continue the lifestyle approach with regular monitoring. George is now 84, independent, active, and his blood pressure remains around 155/86 without medication or complications. His daughter's initial anxiety has been replaced by acceptance of this personalized approach. This highlights a crucial concept in geriatric medicine: treating the patient, not the number. This approach prioritizes the individual's overall well-being, functional status, quality of life, and personal preferences over strict adherence to numerical targets. A blood pressure of 145/88, for instance, might be too high for one 75-year-old, but perfectly appropriate for another, emphasizing that context and individual factors are paramount. If you feel your doctor is solely focused on lowering your numbers without considering your well-being, comment, "Treating me, not number." Regarding dementia risk, studies suggest that high blood pressure in midlife increases the risk of vascular dementia later in life due to damage to brain blood vessels. Conversely, very low blood pressure in late life is also linked to increased dementia risk, likely due to reduced brain perfusion. A moderate blood pressure range, approximately 130 to 145 systolic for most individuals over 75, appears to be associated with the best cognitive outcomes. Pressures below 120 may increase dementia risk, as could pressures above 160. The middle range appears to be the safest for cognitive health. This further reinforces why a universal 120/80 target for all older adults might be detrimental, potentially accelerating cognitive decline by compromising brain blood flow. Additionally, the phenomenon of white coat hypertension, where blood pressure is elevated in medical settings but normal at home, can lead to overtreatment. Conversely, masked hypertension involves normal office readings but elevated home readings, which can go undetected. Home blood pressure monitoring is vital for obtaining an accurate picture. In summary, for most individuals over 75, a systolic blood pressure between 130 and 140 is associated with optimal outcomes. Pressures below 120 increase the risk of falls, orthostatic hypotension, acute kidney injury, and potentially dementia. Pressures above 150 elevate the risk of stroke and heart attack. For adults aged 65 to 75, targets can be slightly lower, with 130 to 140 systolic still being reasonable. Healthy individuals in this age group might tolerate systolic pressures between 120 and 130, but symptoms or orthostatic hypotension warrant considering a higher target. For frail older adults, fall prevention is paramount, making systolic targets of 140 to 150 often appropriate, prioritizing function and independence over a specific number. For those with diabetes, prior stroke, or heart disease, individualized targets, generally systolic 130 to 140, occasionally lower if tolerated, are recommended with close monitoring. Diastolic pressure should ideally be maintained between 70 and 85, avoiding readings below 65. Orthostatic hypotension is often more dangerous than moderately elevated blood pressure and requires diligent checking and potential medication adjustment. I encourage you to comment, "I understand," if you grasp that blood pressure targets for older adults should be higher than traditional guidelines, and talking to doctor if you plan to discuss your target with your physician. Following Eleanor's death, her daughter filed a complaint with the medical board, not due to malicious intent by the doctor, but because he was adhering to outdated protocols. This prompted the medical board to issue new guidance to physicians statewide regarding blood pressure targets in older adults and the risks of overtreatment. Eleanor's daughter expressed hope that her mother's passing might prevent similar tragedies by educating doctors that lower isn't always better for seniors. My objective in creating this video is to disseminate this critical information, empowering seniors to engage in informed discussions with their doctors and prevent unnecessary falls, injuries, and deaths resulting from overly aggressive blood pressure management. If you found this information valuable, please share it with friends, family, and anyone you know who is over 65 on blood pressure medication or experiencing dizziness or fatigue. This knowledge can be life-saving. Subscribe to this channel for up-to-date medical information that may not yet be widely adopted in clinical practice. New research takes time to integrate into standard care, and I aim to bring you the latest findings now. Finally, please comment "too low" if you believe your blood pressure might be too low for your age, "perfect" if you feel your current readings are appropriate, or "talking to doctor" if you intend to discuss your target with your physician. Bookmark this video and revisit it to review target numbers and the protocol for checking orthostatic hypotension. This video could mark a turning point in your blood pressure management, empowering you with the knowledge that a higher target may be safer for your age. Thank you for watching. You now possess the truth about blood pressure targets for older adults. Use this information to advocate for yourself and ensure your blood pressure management plan is tailored to your individual needs, not a one-size-fits-all approach.